Hi, good morning. Thank you all for being here today for Grand Rounds. And Avinash was telling me that we're telecasting also to Ryan Chelsea today. So I just wanted to welcome our friends at Ryan Chelsea as well. We are delighted to have what I've now learned is an old friend of the organization, and in particular of infectious diseases, Demetre Daskalakis, who is the Deputy Commissioner for the Division of Disease Control of New York City Department of Health and Mental Hygiene. Dr. Daskalakis, got his undergraduate degree from Columbia and then his medical degree from NYU Medical Center. And following that, went to Boston for a period of time where he completed his internship residency and chief residency at BI Deaconess in the Harvard system. Also completing a Master's of Public Health at the Harvard School of Public Health. You know, we talk a lot in these grand rounds and in other fora about how broken parts of our healthcare system are. But I hope we all will agree that the public health infrastructure of the United States is a remarkable achievement of the last century and something for all of us to be proud of. And the New York City Department of Health and its infrastructure is a paradigm really for the institution that, like ours, also a paradigm for the country and for the world about how to manage communicable diseases in a way that's both effective and also humane. Dr. Daskalakis in his role oversees more than 1,000 employees and a budget of $300 million. So he's doing a lot of great work in all the pockets of the city where patients need the support of the public health infrastructure. And it's really been very impactful in a number of ways. We're going to hear about the 18-19 measles outbreak today, but also has done great work, for example, around creating a usable and effective LGBTQ provider network for patients who need effective care and confirming that the providers providing that care are good at it. And you can access that by way of 311 now. He's done great work each flu season in terms of managing flu and trying to manage the morbidity and mortality associated with flu in the city. He's done wonderful work with our Legionella pocket outbreaks and wonderful work also, of course, in terms of measles. And as he said to me before we got started, he's excited to talk about that full year of his life and all that he gave. So it's really a pleasure to have you with us, and thank you for being here.
Yeah, thank you very much. Thanks for that very, very kind introduction. So it is nice to come home. So I am still a associate professor here at Icahn School of Medicine, so part of the Sinai family. So really excited to come and actually speak on something that looks like it's off the beaten path. So usually I'm talking about HIV, STIs as my main sort of topic, but measles, as you heard and as you've experienced, was a good solid year of our lives here in New York. And it's not necessarily over, it's just currently better controlled. So I think that's probably a good preface. So I'm going to start by giving you a little bit of measles basics. So I'll tell you, as an infectious disease provider in 2020, I had seen previous to this one measles case, and it was an imported measles case. I remember when that measles case came into the hospital, it was in Boston, it was like a show and tell, because folks in my generation were pretty much sure that because of vaccination, we would never see this exotic disease. And so things have changed. So I'm sad to say that I now know a lot about measles and about what measles looks like because of some firsthand experience. We'll talk a bit about measles trends in the United States, so really showing what it's looking like and what it looked like during the peak of this outbreak. And then we'll talk about the measles outbreak from the epidemiologic perspective, but I think more importantly from the response perspective. And just the preview is that New York City did something that took us from an outreach stance to a regulatory and enforcement stance, which was very different than what's happened before, although not that different than what happened with smallpox many decades ago. So we took a page out of the playbook of smallpox to address this measles outbreak. So it's an interesting voyage, and I'll explain to you what we did and why, and look at it through the eyes of epi. So for those of us who've never seen it or haven't seen it for a very long time, measles is a viral infection. It it presents with high fever, cough, conjunctivitis, coryza, and a generalized rash. So one of the issues with measles that's important to remember is that folks will have a prodrome and are infectious 4 days before the rash appears. They look like a flu, they look like they have something viral with no rash. So I'll tell you that that is one of the parts of measles that makes it the most terrifying from the perspective of infection control, because folks land looking like a fever, no rash, and they enter a healthcare setting, and the efficiency of transmission of measles is that 9 in 10 people who are unvaccinated who are exposed to someone with measles will get the measles. So this is, and you should think of it as one of the most transmissible, most infectious pathogens known to humanity. So, and it starts with a no rash, so invisible. Complications can be pretty severe. There's diarrhea, otitis media, pneumonia, miscarriage, there's preterm labor, encephalitis, and then ultimately about 1 in 1,000 people, specifically children who acquire measles, could die. Additionally, beyond that, there's long-term neurological sequelae that occur. Those are more rare, but once we've seen measles and someone's completely cured or done with their infection, we're not done with what possibly could happen. And also, there are some really interesting immunological articles that talk about the effect of measles on the immune system, and we're really generating some very specific immunodeficiency that happens after measles that may predispose individuals to other viral and bacterial infections. So measles is not good. It's not good to get, and it's really important to try to prevent it. And so, as I said, it is highly contagious. The attack rate is about 90%. It is droplet and airborne transmission. So here's another piece of the infection control nightmare that measles is. If someone comes into the room and has measles and then they leave the room, that room has infectious particles in it for about 2 hours after they leave. And so you can imagine in healthcare settings that aren't as developed as what you have in a hospital, infection control becomes very hard when you don't have all of the rooms in the world. If you're in a small FQHC, if there's not a negative pressure room, if there's not N95 masks looming around. So lots of things that get in the way. The incubation period from exposure to illness is 7 to 21 days. And as I told you, the infectious period starts 4 days before the rash, and it continues 4 days after the rash. So really we have a lot of opportunities for people to transmit measles. In terms of treatment, there's no specific antiviral therapy. Medical care is supportive, and vitamin A may be used for severe measles cases among children. I will give you a little interesting anecdotal story. I will tell you a bit about some of the resistance that we had from parents of bringing their kids to care. And also, again, measles vaccination, which you'll hear about. But during the measles vaccination, anecdotal reports were that vitamin A was sold out in Williamsburg and Borough Park. So if you went to the pharmacy, so they actually had none left because folks were actually, Googling this or getting advice from other clinicians and using this to treat their kids with measles rather than bringing them into care, which is another really challenging twist of the story. So this is the epidemiology of measles in the United States from 1962 to 2019. So this is why when I was standing at Mass General watching somebody with a measles infection, we were all sort of brought in by our more mature and knowledgeable infectious disease doctors to see this case under, biohazard level 4 precautions. So you'll see that there were many, many cases, about 500,000 cases per year at some points. And then something happened, a vaccine was licensed, and good things happened. So really a significant level of control of the measles outbreak. And then what you see is we had little sort of bursts here and there, and then a really pretty significant outbreak that also hit New York City in 1991. And that actually triggered the emergence of the VFC program, the Vaccine for Children program, which actually really gives access to vaccine for underinsured kids. And so really making it really hard not to be able to get a vaccine no matter what your story is. Ultimately, that resulted in a declaration that measles was eliminated in the year 2000 from the United States. Now, I'll tell you that as we go into the 2000s and hit 2018, 2019, we are as of yet unclear whether or not the U.S. will maintain that elimination. That decision has not yet been made, so we'll have to hold our breaths and see. Now, as you saw here, measles vaccine was a really important part of control of this otherwise very significant infection. Measles vaccines administered with mumps and rubella as MMR, or with mumps, rubella, and varicella as MMRV. So there's two options for a measles vaccine. There's no standalone measles vaccine available in the US. It is always in combination. As you all probably know, it is a live attenuated vaccine. It's very effective. So one dose will confer 93% protection and two doses, 97% protection. So it works really, really well. One of the things that you hear in anti-vax conversation is that people get sick from the measles vaccine. So it is true that some folks may get a fever, and about 5% of people will get a rash that looks very measles-ish, but ends up being the vaccine strain of the virus. Now, people don't get that sick from it. They don't have the sequelae of measles, natural measles infection, and then also it's not transmissible. So this attenuated virus, even though it may cause like a rash and a prodromal syndrome in someone who gets it, this vaccine does not then result in transmission of this attenuated strain. So as an adult provider, I literally didn't remember any of my vaccination time frame for children. I will tell you that in the year I did this, I could tell you every micro detail of the vaccination schedule for children. The routine schedule is a first dose of measles vaccine around 12 to 15 months and a second dose of 4 to 6 years. So it's 2 doses and it's spread apart in that way. There's also some very clear daycare and school requirements in New York. So 1 dose is required for nursery through pre-K, and 2 doses are required for grades K through 12, and 2 doses are also required for college. So there are really sort of good strategies that exist in New York to make sure that children are vaccinated. One of the really good strategies that exists to evade that are religious exemptions, which are no more, thanks to the measles outbreak. So we'll talk more about that in a bit. But you'll see a little bit of what it looks like when you introduce measles into a population that has a low level, comparatively, of vaccination than to the rest of the city. In terms of adult recommendations, these I think people will be more familiar with. If you have someone who you don't know if they've had a vaccine or have unknown immunity to measles, 1 MMR is recommended. If they are in a higher risk group like us, healthcare professionals, that's recommendation is 2 MMRs. International travelers, people exposed in an outbreak setting should get an extra dose of vaccine. And people previously vaccinated with killed measles vaccine or an unknown type of measles vaccine between the year of 63 and 67 should get 2 doses. And there's always the alternative, not in an outbreak setting, alternative of actually getting an IgG just to see. So in routine practice, you can just grab a measles IgG to see if folks have been exposed. If someone has been exposed in an outbreak setting and their vaccination status is unknown, vaccinate first and ask questions later. So really important, actually, for almost everything that includes Hep A. So all of the things that you think about, you should vaccinate because the risk is really low. There are very, very few contraindications to measles vaccine. So infants less than 6 months old shouldn't get it. Pregnant individuals and severely immunocompromised folks should not be given a live MMR. Household members of pregnant or immunocompromised folks, however, can be vaccinated because it's an attenuated vaccine. It doesn't transmit. It's okay. Non-immune women can also be given MMR immediately postpartum. So asterisk star star, breastfeeding is not a contraindication. This question comes up all the time. Additionally, one of the anti-vax mantras, and for those of you who do infectious diseases, this will make your head twirl, is that we're exposing people to too many antigens all at once. So the desire is to sort of spread vaccination out in a very strange way. There's actually no evidence that giving people like a bunch of vaccines at once does anything bad, considering that probably this cup of tea is probably more antigens than what a baby gets. It's realistically. although the quality of water in New York City is very high. So just had to say that. There's also some international travel recommendations. So children who are aged 6 to 11 months old can receive an early extra dose of MMR before international travel. So we pulled this tool out during the outbreak, and I'll tell you in a bit. Importantly, it doesn't count toward their 2 for school, because their immune systems aren't so good yet. And so this is just to give them some temporary protection. Remember, at less than 6 months old, if their mom is immune, then they still have some passive immunity. So this is, and also there's risk of dissemination of the vaccine strain in younger babies. If they're children who are age 1 to 4 years old and they're traveling, they get an early MMR. That actually counts toward their count. And if they're over 4 years old, they should have 2 MMR before they go. And ideally, you want to get that in their arms or their thigh, depending on their age, 2 weeks prior to travel, so that it has a chance to actually have a serologic response. Okay, so this is what the world of measles looks like in a universe where we thought that we had nearly eliminated measles, and in the US, we had achieved measles elimination. You'll see that unfortunately everything is going toward a nice shade of burgundy. So the US remains orange, which means that it's somewhere in the middle in terms of cases. But I think that everyone who works in medicine in New York City can attest to the fact that we are an international city, and that we are not immune from getting importations of things like measles or novel coronaviruses that you may have heard about. So I think that it really is, it's important that a preparedness stance is important, but then also like strategies where we do have the ability to prevent infections are important. Like I will tell you that I as a fellow and as an attending, always heard about the idea of herd immunity. For a year, I lived it, because it seemed as if, and we'll talk about this later in the talk, that populations that had a high level of vaccination for measles, mumps, and rubella were in effect a wall of immunity that prevented transmission of the virus. So it's fascinating, like how very specific and community-based the outbreak was, and how vaccination status was so critical, and vaccination uptake and herd immunity to be able to achieve this. So the goal is 95% or more people in a community need to be vaccinated and immune to actually generate the herd immunity that you need to protect others. Well, why is this herd immunity so important? So it's not just because you don't want someone who's healthy to get measles. It's because you don't want the immunocompromised person who can't get the vaccine and the pregnant woman who can't get the vaccine to get it. So by protecting individuals, you're actually creating a sort of blanket of protection for others who aren't able to get vaccinated, or somehow have limited immunity because of their state, like chemotherapy, HIV. You can make a long list of why it's important. So then when you look at this year by year, you'll see that in the US, there are definitely moments where we've had increases in measles cases. There were outbreaks in 2014, a small one. They're here and there, and a lot of them have to do with importations. And the ones that 2014 isn't just importation, but also local transmission. Our 2019, 2018, you can see, was terrible. So about almost 1,600 measles infections. Most of them were locally transmitted, and you will soon learn that the majority of them linked right back to your favorite city, the Big Apple. So most of them had a link to us one way or another. So it's the largest number of cases that were reported since 1992. Again, 75% of cases in the US in 2019 were linked to New York City. And let me take that back. It's New York City and state, because there was an equivalent outbreak happening in upstate New York. The majority of cases were unvaccinated. I will share the details of their vaccination history when we talk specifically about the New York City outbreak. Measles was reported in 31 states, and the way that it was sort of looked at nationally was that there were 20 outbreaks. I'm going to tell you that New York City, if you actually look at our epidemiology and our epidemiologic data, our outbreak, the one outbreak, was 31 separate chains of transmission. You're going to see what it looks like when you have 31 chains of transmission in a big city from the perspective of the public health response when you talk about contact tracing. And you'll see how many of your tax dollars went into the work to actually control this. And I think I'm glad you're sitting down. Yeah. So interestingly, the way that these chains of transmission mainly began was like a spark being thrown into kindling. So you had one person who was traveling from a place that has an outbreak, so Israel, Ukraine, Philippines, landing in a community that, because of anti-vax mythology, have been convinced that there is danger in vaccine, and you create a wildfire. I will then also tell you that because of the anti-vax mythology, we also had the kindling looking for the spark. So remember chickenpox parties? Anyone? We had measles parties. And so we were seeing people who were bringing their children to measles cases to try to get measles. And so that's at least partially what we were up against. So we're going to leave the story of the US and go to your favorite city, New York, and talk a little bit about our measles outbreak that we had here and get you to the point of what we did and what we had to do to declare a public health emergency in Williamsburg specifically to be able to bring under control something that was slowly careening out of control. The measles outbreak in New York began in October 2018, and yes, we have a story of one human, an unvaccinated child from Brooklyn who got measles in Israel when a large outbreak was occurring, landing into their household, and a small burst of measles happening because other children were unvaccinated, and then some transmission that happened outside their household. The entire outbreak from beginning to end in New York was 649 cases. So if you did the math, we're a really big piece of that outbreak. And realize New York State then has an additional like 400. So like New York City, New York State makes up the majority of that outbreak. So we declared it over September 3rd, 2019. As I said, it was the largest outbreak in the US since 1992. And again, just like what happened throughout the country, we experienced these little sparks entering the kindling from Israel, UK, and Ukraine. And in typical New York style, since we think we're our own country, we considered New York and New Jersey importations as well. And so it's true. So we had a lot of folks coming in with measles, entering the right population, and poof, like firestorm. And I will tell you, there is one event that took the measles outbreak and took it from like near control to completely out of control for a bit. And I will get to that when we get to the epi curve, and it is quite a story. So the bad news is that the kindling was the Orthodox Jewish community. So there were very clearly a population who had some vaccine hesitancy to begin with, and who most recently were aggressively targeted, and I will show you what that means, by anti-vax propaganda to convince them that vaccines were unsafe, and in some scenarios that they were actually against Talmudic law. And so very interesting manipulations by folks who were actually outside of the Orthodox Jewish population. So I mean, a little anecdote. I will talk about the emergency declaration that we did. And once we declared an emergency with some very interesting strings attached, we immediately got sued, as you'd expect. Thank you, Robert Kennedy Jr. So we were sued, and we went to court. And I imagined that the folks that we would see who were in the room with us, who were suing us, were going to be folks from the Orthodox Jewish population. That is not who was there. It was folks who were wearing anti-vax t-shirts, had propaganda with them. It was a completely different demographic than who was getting the infection, but it was the demographic that actually had worked to target this population. And you'll see the dangerous and disturbing work that they did. I will present some of that, though not give them a lot of airtime. So this is what our outbreak looked like. So you'll see we started again in September. We had a little bit of a ditzel. So you'll see like Brooklyn, Williamsburg, and Brooklyn Borough Park were sort of neck and neck for a while. And then sometime in January, although we had, and I'll talk to you about these in a moment, we had told schools, yeshivas specifically, in Williamsburg and Borough Park, that they need to exclude all children who are unvaccinated, whether they have medical or religious exemptions. and that they may not come back to school until they get vaccinated. So it is kind of hard. I mean, medical exemptions are medical exemptions. And so some kids had to stay out of school for a while. But what happened was in late January, early February, there was a single yeshiva. We visited them in December, and that yeshiva had not excluded children. So we asked them nicely, please exclude children. And then they did. We went back and inspected them to make sure. And then we left, and they brought those kids right back. And the next thing that happened was one child imported measles and went to school. And that one child transmitted measles to 41 other kids. And those 41 other kids then transmitted measles to their friends and to other people. And then we had measles parties. And so what happened was we went from what was looking like the beginning of control to this, a giant explosion in new cases. And when you have a giant explosion in new cases, you have a giant explosion in contacts. And so we don't just do the people who have measles, we have to work and monitor the people who don't have measles but have been exposed. And so this very single event created a completely different environment. I'll say many of the other yeshivas did a very, very good job in excluding kids, but this one that we actually did a press release, we closed the school, it was very high drama, was really the reason that we had, again, a pretty significant firestorm of measles cases. In terms of the demographics, 60% were male, 40% were female. 93% of them were Orthodox Jewish. Specifically, they were Hasidic. They were in sort of those sects, mainly Williamsburg. So Borough Park had a signal, but actually simmered down pretty quickly in the story of the outbreak. But Williamsburg was a hotbed. And there were also 6% of individuals who were Latino. And it was really interesting that their pattern of transmission was very different, and very often they were immunized. And so there is some thought that there's like a serological reason why there may not be as robust a response to measles in some Latinos. Very interesting. CDC is postulating. We don't know an answer. But that's what the outbreak looked like from the demographic perspective. So this is what it looked like from the perspective of age distribution. For those of us who aren't pediatrics minded, these are the ones that were imminently preventable, because they were right in that sort of sweet spot for vaccination. So about 277 of them were. Others were also preventable. These were the ones that we really should never have seen. They were mainly unvaccinated. So 86% of the folks who came down, the kids mainly who came down with measles, were unvaccinated. So you'll see age less than 12 months, 100, age greater than 12 months, 376. So they should have gotten some vaccines there. Of the vaccinated, many were under-vaccinated with only one prior MMR. And then 94 of them had an unknown vaccination history because of our precise definition of vaccine history. So it's not just, oh, yes, I've had the vaccine. It's that we have documented proof of the vaccine. So this is mainly adults. You'll see soon that in New York, we have a citywide immunization registry. The vaccines given to children are mandatorily added into this registry, which means that we have a great ability to see what's happening with vaccination trends. Sinai and other places like health and hospitals are moving toward adult vaccination reporting. And when that happens more universally, we're going to be able to get a better sense of the lay of the land for vaccines for adults as well. But with children, we have a really sensitive system of seeing what happens with vaccines. Again, when you look at this, these are folks who should have had a vaccine, and these cases were likely preventable. Remember, one dose is probably 93% effective. Now, 1 in 1,000 people with measles will die. Statistically, thankfully, we had 0 deaths. It was a miracle. However, we had 49 hospital admissions. Of those, 20 were in the ICU, usually with respiratory distress. 37, so 6% had pneumonia. Otitis media occurred in 10%. Diarrhea was fairly common. And again, we don't know about any encephalitis, and we don't know about sort of the longer-term neurological sequelae because they can appear 10 to 12 years after measles. So we will see what happens with that. So not a free ride from the perspective of the healthcare system. Thankfully, no one passed away. So there was lots of sources of infection. So there was domestic and international importation. So we know like this sort of spark again landing into the kindling, but then also household members and relatives. We had folks who were in shared residential buildings. So remember, depending on the air handling of the building, being next door to someone with measles could potentially mean a measles exposure. So we definitely saw transmissions within buildings, neighborhoods and friends, daycares and yeshivas, and boy, oh boy, healthcare associated. So one of the hardest pieces of this was the sort of infection control that had to happen in certain practices. I'll tell you, there's one practice in Williamsburg that did the majority of measles work. And, they were not really designed to have really sort of rigorous infection control practices for a measles outbreak. So ultimately, as part of our response, we actually deployed Department of Health staff to actually be stationed at these venues to actually do screening outdoors to make sure that kids didn't come in with symptoms. So really, we had to be very, very hands-on with what was happening from the infection control perspective. So as I told you, we don't just look at the cases, but also exposures. So the magnitude of this response was that we had over 20,000 exposures related to these about 600 cases. And the majority of those exposures were in medical facilities. Because again, that prodrome, it's not always like, oh, that place is terrible. How could they possibly let the measles case go through? It's like that kid had a fever and got seen because they had a fever. And oh boy, now they have measles. And everybody who was in that ER 2 hours after that kid was there, we have to think about doing something with. And so really a lot of exposures. And so again, like I said, not every place is so well resourced to be able to have negative pressure rooms. So a lot of exposures that happened just because there weren't appropriate like air handling, inadequate isolations, and also there's some delays in reporting cases that really made things difficult for us in terms of exposures. Of all of those medical facility exposures, we had 21 cases that were acquired in healthcare facilities, and it was only a small number of facilities because of the fact the community is very tight and only goes to certain places for their sort of routine healthcare. So all of this was going on, and then we had a very long-standing response. So we did something that's called a divisional emergency activation, which is my division, pulls people from all pieces with, if you worked in STI, you weren't safe, I pulled you into measles if I needed you. And so we worked to sort of increase vaccination in the neighborhood. We worked with the schools, we excluded kids, but then ultimately we bubbled up that one yeshiva with the 41 cases and all of the associated exposures and new infections resulted in a shift in our strategy, a change in our work to go from supportive to regulatory as well. Just to tell you what it looked like, over 500 of the Department of Health staff worked on the outbreak. That's 7% of the entire agency. We set up a dedicated call center, 24 hours. We investigated all reported cases. So if we heard of a case or a potential case, they had a full investigation. I told you we stationed Department of Health staff at high volume facilities at the epicenter of the outbreak in Williamsburg to assist with potential exposures. We did a lot of contact identification notification. We performed over 3,000 measles tests of one variety or another, and you paid $8.4 million US for it. So there was also CDC funding in there as well, but the majority was city tax levy dollars to support the work. And so this outbreak was and this estimate doesn't include what happened in healthcare. This or what's happened in this facility. This only includes the dollars that we spent in the Department of Health. That also doesn't tell you about the opportunity cost of what happens when I pull a staff member out of HIV or STI or tuberculosis for a year to do measles. So some other work is not happening to be able to do the work for this outbreak. That nothing that a little vaccination couldn't have prevented. So an important message. So this is what it looked like when everybody got super dizzy and crazy with case investigations by status and week of the outbreak. So when we had our local divisional activation where we didn't get the entire agency involved, we were okay to be able to handle a lot of case investigations. Well, When we had that one yeshiva that caused that firestorm and our case investigations got so high, we had to actually activate the emergency response system for the entire agency, which meant that no one was safe. So we were pulling folks from all over the department to come in to do work. And that's how we got to that lofty height of 500 plus people doing the work. And by sort of creating that all hands on deck strategy, you'll see that we were able to slowly bring the outbreak into control. We, along with outreach, also made it very clear to physicians and other providers in the area that we had to have revised strategies for vaccination. So we set out alerts that said if you had someone who was residing or spending time in areas with ongoing measles transmission, so at that point it was Williamsburg, Borough Park, and every now and then Crown Heights would come to visit, but they would go in and out pretty quickly because they had a really great vaccine response there. We also reinforced the international travel recommendations. And then locally, we said, if you have kids who spend time or live in this area, you should do that extra MMR dose at 6 to 11 months, even though we know it doesn't count toward the 2 for school. We also talked about that sort of international travel idea of accelerating the second dose. So folks who are 1 to 4 years old were also told to get a second dose if possible. And that folks really had to have proof of immunity in that neighborhood to make sure that things were okay. We did a lot of provider outreach, health alert after health alert after health alert. Sorry about them. There's a lot of them, but we have a lot to say to you. We reminded providers to recall unvaccinated patients. We did a lot of clinical and infection control technical assistance. We distributed posters everywhere in English and Yiddish to medical facilities. You will see some of them. We also checked stock of providers from MMR because we were hearing that folks weren't buying enough. So we were able to give them vaccine if necessary from either city money or from Vaccines for Children or the adult equivalent program. And then we gave a lot of guidance around post-exposure prophylaxis and home quarantine. We developed very specific materials for medical facilities with exposures, telling them what to do and how to do it, including post-exposure prophylaxis, since for some people that's an MMR and for others it may be immunoglobulin. So we made it very clear how and to do it and how to access the immunoglobulin. We gave tables about post-exposure prophylaxis and home quarantine, and we had a very for notification of exposed persons that gave them all the information that they needed in terms of maintaining their own health. We also did a survey early on of infection control practices in venues with suspected cases, and it was pretty variable what we saw. 93% of them just closed the room for 2 hours. 87% did screening for measles by phone to prevent folks from coming in. In fact, we have stories of patients being driven up to the clinics in a car, and the doctor and phlebotomist running out to see the patient in the car and then going back in so as not to bring them into the facility. Lots of signs about measles symptoms, lots of new protocols around measles prevention, and then again, alternate isolation practices like seeing patients outdoor, a measles entrance, I kid you not, to some of the clinics. Evaluating measles patients after hours. So you would see folks, you'd say if you have a child with a fever, all the kids with fever come in at 6 p.m. But that also means that all the kids with fever are together. So that's another story. And then also home visits, we were seeing some of that as well. So people were very creative. And then there was the community engagement. And so we had meetings with local religious and community elected officials. So you can see that's me, with the Commissioner of Health in the middle, and the Deputy Commissioner of Environmental Health, who is in charge of daycares and nursery and all of that good stuff. So all of the sort of registration of those. We collaborated with a lot of key community partners. Actually, one of the really cool things is that the measles outbreak generated new community partners. So where we had no community sort of partners in that neighborhood, the Jewish Orthodox Women's Medical Association was born out of the measles outbreak. The Vaccine Task Force was born out of the measles outbreak. So really amazing things, that good things happened as well as scary things. We sent letters to parents through schools, letters sent to households with unvaccinated children. So here's a really cool thing. In our city immunization registry, we know who's born because we get birth certificate data, and we also know who's vaccinated. So we're able to figure out who's been born and not vaccinated. So then we know where they live because we're Big Brother. And what we can do is generate a list, or sister, depending on how you look at it. We generate a list and we just mailed them letters. The letters at first were pretty nice. And then I'll tell you that toward the end, they weren't so nice, with threats of fines and everything else. So you'll see that in a moment. We also did robocalls. So I live in Williamsburg. I was so tired of them. Like, I would get a robocall every day. Are you vaccinated? Are you vaccinated? So 75,000 robocalls each time, and we did it multiple times. We also did live calls to that same group, just giving the option to talk to people about measles vaccination. And another really cool thing that we did was with that Jewish Orthodox Women's Medical Association, we created an immunization hotline, because we'd heard from the community that there was a lot of stigma about going to a clinic to get vaccine because of all of the anti-vax rhetoric that was flying around. And so folks could call this immunization hotline, and if they wanted to be vaccinated, we would deploy visiting nurses to go to their homes and give them a vaccine. We tried everything. We also did a lot of really good media and community education. You'll see some of this in a moment. It focused mainly on print and digital media serving the community, like in newspapers, WhatsApp. We did all sorts of things, English and Yiddish. We co-branded it with a lot of partners that were in Williamsburg. So Hatzola, which is the ambulance group that sort of works with the community, co-branded things with us. So we had a lot of sort of support. We distribute a lot of amazing materials. There's a New York State developed book called Tizim Gazette, which I hope I said okay. I could never say it, but it is a book that sort of talks about the importance of vaccination and the safety of vaccination. But then also the Vaccine Task Force, a new group, created something called PI. And I'll tell you why it's PI in a moment. But they created PI, and they worked on a slice of it that focused on MMR. And so we distributed the Tzim Gazette and the PI to over 29,000 households via mail. So this went out in a very large way to the community. These are some of the ads that we put up around Passover. They're, as you can see, in English and in Yiddish. And they really were developed with the community hand in hand to sort of be a good message about the importance of vaccination around that important period that was in the middle of our outbreak and meant a lot of sort of folks intermingling and traveling. And so we also, throughout Williamsburg, posted these, which was our effort to show you what herd immunity looks like. And why it's important to vaccinate to protect more susceptible folks in the community, really making it sort of a rallying effort to try to get folks motivated to get measles vaccination. We also did school and, are you tired yet? I'm tired. School and childcare outreach. So on December 7th, 2018, we, as I told you, required exclusion of students with medical and religious exemptions in impacted zip codes. Obviously, no longer applies. We also started doing weekly audits of every yeshiva in Williamsburg. So we would go every week to 101 facilities, initially taking a look at how things were going and giving them technical assistance. But then after the emergency order, we weren't just giving technical assistance, we were writing violations and closing them if they were not in compliance. Like I told you, when we took that more regulatory stance, it ended up that during this outbreak, we closed 12 schools temporarily for failing to provide access to medical and attendance records, or for having students who did not have the required number of MMR doses to be in attendance. So we took a very, very regulatory stance to try to enforce vaccine. So this all really revolved around what was a public health emergency that was declared by our commissioner on April 9th, 2019. And this order was a little seismic. It was based on what had been done in Boston for smallpox when there was an outbreak. So there was precedent. Every adult who lives, works, or resides in Williamsburg, we had 4 zips that we included for Williamsburg, who had not received the MMR vaccine by order of the commissioner must be vaccinated. So it's not like forced vaccination, because you don't have to be. We say they must be, because if they don't get vaccinated, that's fine, but they may be subject to a $1,000 fine. So that's sort of what happened. It wasn't like we were bringing folks in and saying, you must get vaccine or else you can't leave. It was, here's your choice, vaccine or fine. And the only people who didn't have to get vaccine were folks who had a medical exemption that we had to approve. Ultimately, 232 individuals actually got vaccine parking tickets. So they were given these violations and they were told that they owe $1,000 for not demonstrating evidence of immunity. The good news is it's really increased vaccination in Williamsburg a lot. You'll see that in a moment. And most of these were canceled. So the reality is that the point of this public health order was not to raise money for New York City. That's what parking tickets are for. But thank you. But the reason, just kidding. But the reason was to really increase vaccination, to really give like a stick as opposed to all the carrots that we were giving to make it move. And then ultimately, once the outbreak ended, we lifted the emergency order and then we went back to business as usual in Williamsburg. And so again, this is our epi curve. And so the higher the bar, the more number of cases. And you will see what happened to vaccine with our various interventions in the next slide. But we, again, had this thing under pretty good control in December, but when it went out of control and we were seeing how far out of control, a more drastic step had to be taken. And that's really why an emergency decree. And so it wasn't just about that. It was also about the anti-vaxxers who were coming to Williamsburg spreading lies and misinformation and dangerous misinformation. So this up here, it looks really nice, right? Nice and glossy, really official. It's something called Peached. It's this document by this organization that it's called Peach, that was about telling people good information about vaccines and how dangerous they are. And so literally autism epidemic, talking about, you can see it was just like, it just spewed so much lie. So thus, the vaccine task force developed pie because they were going to make pie out of the peaches. So it was very cute. And so that was very sweet. And so this is sort of the propaganda. So this was mailed to as many households as we mailed our stuff to. So we had this like competing effort. And this is a real live poster of a hotline that was put together during the height of the vaccine. Please note that a vaccination needle is depicted as a gun and a giant declaration that vaccines are dangerous. So we were up against very active forces in hand-to-hand combat, trying to prevent us from ending the epidemic of measles in this area. But here's what happened with vaccines. So remember, our city information registry is magical. Like, we really see what happens with vaccination in real time. Like, we do something, we look in the registry, and we can see what's happened. And so this is limited to those kids that are in the sweet spot of prevention, 12 to 15, 9 months old. So you'll see, before we declared the outbreak, we had our normal back to school rush. That's great, that's normal. Then we declared an outbreak. And in a lot of other, one more thing, sorry. The dotted line is the year before, and the red line is outbreak year, just so you can see the comparison. That's important. So back to school rush, about the same in both years, not that different. We declared an outbreak and bang, giant amounts of vaccination were happening. Like, so many people were vaccinated. So it's not like we're saying, this entire Orthodox Jewish community doesn't want to get vaccine. Most of them were like, yeah, let's go. But the ones who had their minds poisoned by this anti-vax rhetoric, they weren't playing this game. And so we had a lot of trouble. So we added school and child exclusion letters. So your kids can't go to school. Well, that created a little ditzel in vaccination. People were interested and they got some vaccine. And then we got to this phase here where it was pretty flat. And remember, January, February was when we had that yeshiva with the explosion. And so we weren't looking so good in terms of what was going with vaccine uptake. We started this emergency order and we had a resurgence of vaccination, like really significant surge in vaccine. And then we ended the story because we were out of the woods, but we still had, thankfully, this nice, healthy back to school rush. So citywide, during the outbreak, about 190,000 MMR doses were administered, and that's a 14% increase versus the same period last year. In Williamsburg alone, about 12,000 doses of MMR were administered, and that's a 54% increase compared to the year before. So whatever we did, it worked. And in general, in Williamsburg, boy, are we getting close to herd immunity, because we went from only 80% of kids having one dose of MMR to 91%. So really getting there. Borough Park, I'll tell you, they were high to begin with and got even higher. So I'm not going to even show you the numbers, but ultimately we still had an increase of vaccination in Borough Park, up to 42% increase. So really significant impact. So why did this outbreak occur? Multiple importations. I told you that story. There was vaccine delays and hesitancy, which is, again, one of the really sort of important pieces of all of this anti-vax stuff going on, which is that parents are worried about giving all these vaccines at once because of all of this mythology that too many antigens are being presented and blah, blah, blah. There's a lot of aggressive misinformation coming from anti-vax propaganda. We had multiple chains of transmission. So we weren't just looking at one outbreak, literally 31 outbreaks in Williamsburg and Borough Park were what we were chasing. Really amazing. We had also, there's some sort of demographic issues with the Orthodox Jewish population that also made it potentially easier to transmit measles. In general, there's a lot of kids, large households, and a densely populated with dense population with lots of congregate settings, including temples and yeshivas and all of that. Also, there were places where we were unable to implement control. Parents weren't seeking medical care for infected kids. Patients were not forthcoming about exposure information. And we were learning that kids were getting sick, were getting sent home, and then parents would bring them into the clinic to get a serology to prove that they're immune to measles to bring them back to school. And so there was also like that perverse disincentive created by the exclusion. So really complicated. Now, why didn't the outbreak spread? So I want to go back to that notion that that populations with high levels of vaccination really worked as a wall of immunity. So we would see a case that would like pop into, we had one that like was in Hell's Kitchen, actually, not so far from here. Guess how far that one went? Nowhere. It was someone who was a worker that worked with the Orthodox Jewish population, was exposed, came back home, not one more case, done, dead end. And that's because we have high overall vaccination rates in New York City. As a gauge, public and charter schools in New York, about 99% compliance with school immunization requirements, and a very small number of medical and religious exemptions. Private schools, it's a different story. Among all private schools, 98% were all good from the perspective of measles and mumps. At Orthodox Jewish schools, 97%. So it's not as good. And only 97% were completely vaccinated. So there's definitely like a difference between the schools. In terms of our response, we had a lot of challenges. So I stand here like a year later saying we shifted from like a supportive to a regulatory role, but I had no capability in my disease control division to write a violation. I have limited capability of doing audits. So we had to figure it out really fast. So we went from not having an infrastructure, but because we activated our emergency response, we were able to actively ramp up our audits of school and childcare. We also learned that we had to move really quickly for post-exposure prophylaxis. You have about 72 hours to give that dose of NMR after an exposure. We had those measles parties that were working against us. And then frankly, there was a lot of mistrust. So it was hard for us to do a vaccination event in Williamsburg when we were also saying, if you're unvaccinated, we're going to fine you. So if you come to see us unvaccinated, do we give you a vaccine and a violation? It was very challenging. Also, we saw that religious exemptions were steadily increasing in Williamsburg and in Borough Park. So those were some of the areas that had some of the worst. And there was actually one school that had like 37% of their kids had religious exemptions, which is shocking. And so those are now goodbye, they're gone. And so the good news is we're not seeing a surge in medical exemptions, which is what California saw when they got rid of religious. So in terms of our lessons learned, it's really important to identify populations and communities at risk and look at sources really aggressively. Our citywide immunization registry is a miracle. That we were able to know like in real time what was going on in New York City with vaccine. It's also important that, there's a lot of equity issues that came up in this, but it was really important to look at geography, religion, and ethnicity and make sure that your team includes people who really understand that community engagement, because it's not easy. Our cultural sensitivity work was important, as were translations. I'll tell you a fun story. New York State put out an ad that had a bad Yiddish translation. To this day, we still get emails about it, and we're not New York State, we're New York City, but the brand confusion, like their bad translation, really still haunts them now a year after the outbreak. And so we not only had translators look at it, but we had folks that work in our agency who live in Williamsburg and Borough Park who speak Yiddish review it as well, and also folks at City Hall who spoke Yiddish reviewed it as well. So we had many layers of people making sure our language is appropriate. And also, there's the importance of establishing relationships before an outbreak. We had many relationships with providers, but we didn't have a lot of community links beyond the schools because there weren't a lot of organizations that were amenable. Now we have at least 3 really important ones. I will again scream from the mountain the importance of the Jewish Orthodox Women's Medical Association, amazing. Our vaccine task force, and we actually have a group of Orthodox Jewish and Hasidic providers who meet quarterly to talk about other health concerns among the community. So we have like a nice group of folks who are working in tandem with us. Additionally, some really good regulatory things happen, legal things I've already said a couple of times. We literally were jumping up and down, dancing in the streets when we heard that religious exemptions were repealed in New York State, because that was a lot of what we were working against. And so the day that those went away was a very exciting day for everyone. And so far, this has managed to navigate through a lot of legal challenge. So obviously, measles right now is controlled. We have a lot of activity in measles outside of the US and outside of New York. Flights land here daily from those places. So international travel still continues to be a risk, and future importations are a real thing that we should expect will happen. It's been fabulous to have that new religious exemption law, so we don't have to sort of follow that. And then ultimately, we are still having really important conversations about how we can continue to fight our anti-vaxxers in hand-to-hand combat. I'll tell you that we have some disturbing news, which is that the anti-vaxxers have shifted their attention from Brooklyn, from Williamsburg and Borough Park, and now they've squarely put their focus in Harlem. So we have like a whole new universe of propaganda that's hitting a whole new population who at baseline has a pretty good level of MMR vaccination. That's the measles story in a very big nutshell. So I think we have a few minutes for questions, which is rare for me because I usually talk forever, but let's take some questions. Hello. And thanks for coming to the mic so I think the other folks can hear you as they run away.
Great job.
Thank
so,
you.
As you were saying, the shift from the anti-vaccine group is now in Harlem. How are you going to use what you've learned in the Brooklyn community to collaborate and inform them in advance to prevent a potential another fire?
So great question. And so we're literally working on this now. So one of the really important characteristics of the Department of Health is that they really have a great strategy for neighborhood-based intervention. So in Harlem, we have one of our health action centers. And that means that we have really good, boots on the ground in that environment. So we're working now to identify both medical and community-based organization providers. We're going to be doing pretty aggressive outreach to them in advance of all of this sort of propaganda that we're hearing. So we have like a foothold. Again, we are landing there with better vaccination rates in Williamsburg and Borough Park. So we don't want to lose ground. And so the answer is our community engagement strategy is already beginning to go into overdrive specifically for that neighborhood and that area, because we're not going to have this happen there. And I hope, I can't guarantee it, that there may be some stronger statements about anti-vaxxers hands off Harlem. So that may be happening, but we have to sort of see with our community if it actually makes sense. Very often when you shake the anti-vaxxer nest, they do things that are pretty bad. So we're trying to figure out how hard we're going to rattle their cage.
Hi, Demetre. Bernard Kamens. I wanted.
Oh, hi there. I'm like, I hear a voice coming from somewhere. Hi there.
But anyway, I'm the medical director for infection prevention for the system, Mount-Sinai system, and I actually have a question about the American Samoa experience.
Yeah.
Which, you know, with 3,000 cases of measles, they had like 40 or 50 deaths, and so did they call you at all about your own?
Yeah, we're in very, very close consultation through the CDC with Samoa. So I think we have we're giving them a lot of technical assistance and a lot of strategies. I think also, spoiler alert, there's going to be a really big article coming out from us that really sort of tells this entire story. So other jurisdictions can use, including appendices that include our commissioner's order and our declaration of emergency, so folks can actually use that for something useful. So we're working with them closely through the CDC, and I think a lot of efforts going there, but it's just I think that they have a pretty uphill battle there as well.
But do you have an explanation why they had so many deaths compared to our experience?
I don't have the answer to that. I can't really postulate without completely hypothesizing and not knowing some of some other data. But I mean, again, that death rate is extraordinarily high, and I think usually places that have higher death rates usually have kids who have some nutritional issues. And so that's generally what you see. So in areas where you have high measles deaths, there tends to be an issue around just baseline health of the population. I can't answer the question as to what it specifically is, but there's going to be some baseline health issue or nutritional issue that may be participating in their outcomes.
Hi
there.
How are you doing?
Good, thanks.
How are you? The very good talk.
Thank you.
You vaccinated, we all vaccinated more people. There was any data on more serious side effects, the ones that are very rare, but they are present from serious allergic reactions?
Yeah, we don't. So we don't. That's not part of the surveillance that we do for vaccines. Although I can tell you that we did not have. I think we had about 10 or 11 vaccine strain cases that were related to vaccination. So that means that someone came down with a measles or a measles-esque syndrome, and they got a PCR of their blood, and that blood PCR, when the virus was typed at the CDC, was a measles vaccine strain. So we did have some folks who had the rash and fever after measles vaccination. We did not get reports of any serious adverse side effects to the measles vaccination in the community. And of course, remember, one of the side effects that is not a side effect is autism. So that's been debunked and disproven. So I think important to remember that sort of normal vaccine side effects happen with vaccines. Vaccine strain measles can happen theoretically and does happen on occasion, 5%, but not linking it to any of the other sort of strange anti-vaxxer side effect conversations that we hear. Yes.
St. Luke's, this is a more far-reaching question. One of the methods I use to educate patients about the value of vaccination is that all these childhood viruses are neurotropic, as is influenza. And as a consequence, one of the striking examples we can see of adult recrudescence of a childhood infection is shingles. Mm-hmm. Now, why does shingles come back? Is along a neural tract, a nerve root. And we don't know why it selects different nerve roots, but it does. And then there's some serious consequences, including meningitis. So that tells me that even with, quote, natural disease, you may not have lifelong immunity. But because of the change in our immune status as we age, our immune surveillance becomes diminished. And as a consequence, we have serious diseases. Now, we're looking for a cause of neurodegenerative disorders. And I cannot believe that some of these viruses that stay in our brains forever have no effect. And there's some evidence now that herpes, type 1 and type 2, may be involved in brain degeneration. So to me, it seems if we can start tracking data now, because now we have the capacity to do this with our digital techniques, we can actually begin to trend what happens in a lifetime, because very often research is what I call snapshots, photographs in a limited period of time. So I'm wondering whether, and that modality, when I tell patients, you you really want this in your brain for the rest of your life, they kind of say, oh, well, maybe not. So maybe that will counter the autism nonsense too.
No, that's great. I mean, I think that the more sort of conversations like that we have with patients about natural disease being a lot different than a vaccine that doesn't actually cause disease is really important. I think, any tool in that toolkit is really important. So thank you for that counseling strategy. Hi, how are you?
Good. I'm Chrissy Woods. I'm the hospital epidemiologist here. One of the big problems that we had here during the whole outbreak, and I'm sure you had as an extension as well, is that we do have a very large footprint here for maternal child health. And so you had all these women coming in, and people in the city who come from different places who may not necessarily have their vaccine records, and then there was a question about what to do serologically for them to figure out if they're immune. And initially, the cutoff had shifted, at least from the clinical labs, because we understand it's not as good as the plaque reduction test, which nobody does commercially. So I was just wondering how you felt about the fact that the cutoff shifted. Did you think that was a necessary thing to do? I know we sometimes sort of felt a little bit at sea with it because we have the understanding, especially as infectious disease physicians, that what we see on paper may not reflect reality. And certainly, even having a test that's within immune range may not sort of give us that feeling that it's okay. But when somebody's pregnant and really feels extra vulnerable, it was a difficult thing to sort of counsel them. So I wanted to have your opinion on the change in the cutoff, and if you were supporting that.
Yeah, I mean, I think we supported it from the perspective of sort of making, of sort of having a higher sort of level of security, again, around the sort of issue that, especially for more vulnerable populations who, especially kids and pregnant women. So we supported it. I think it is obviously complex, and so many things happen in maternal and child medicine around the time in terms of, people having to demonstrate and prove immunity before coming into PICUs and all of this. So I think definitely we supported that change. But again, everyone was aware of the complexity of that shift and sort of the messaging. Yeah, great. Thank you, everybody. Thanks for coming.